Thank you all for coming. And here you see this wonderful team of senior colleagues who preceded me in the role. And two of them are here on the front. Hands up, Andrew and David. That's great. And you'll see and hear from them shortly. And John Saville, who, as many of you would know, is in Melbourne, sent us a message. And you'll hear this message and see John at the end of my presentation. And the slides are changing. That's great. I am going to keep to time, so it's going to be very fast because we have a packed program. But I feel some things about us, the Chief Scientist Office, and all of you have to be said, particularly now that life is maybe not the easiest in health in Scotland. So, first of all, I believe that one of the hugely important roles of CSO is as a research funder. And you see here data since 2016. But of course, that's been done from the very beginning, from the first chief scientist, 1973. You see some examples here. There are two funding committees, clinical and public health, as always in everything we do. You see colleagues who run it, and you see some examples of very important studies that funded early. Frequently, this is the first grant of principal investigator. Many people in the room received their first grant that set them on their career as principal investigator from the CSO, and that's why it's so important. And you see some of these titles, clearly no time to go through them, but they have influenced Scottish policy, or maybe world policy at large. And then there are, of course, young investigators, many of them here. I hope prizes will be won today. And we need fellowships. We are frequently told we don't have enough. So I did some counting. You know, it's important to do a bit of mental arithmetic. And over the last 10 years, we have founded 286 fellows at different levels. And the way this is presented is to show that continuity, that end-to-end pathway from pre-doctoral through doctoral to postdoctoral awards. Over the last few years, we have added innovation fellowships. This is for entrepreneurial colleagues in health service, and we'll talk about it a little in a minute. And the second number, 76, and I think many of them in this room, 76 current fellows are with us, funded by the CSO this year alone. Now, that type of environment provides possibility for Scotland to lead clinical science internationally. And I only have time for one example, so I've chosen one from cardiovascular medicine, which, as you know, is close to my heart. And this is a really important study led by Dave Newby from Edinburgh. Huge collaboration, published in New England Journal of Medicine, you know, the best medical journal in the world. It changed clinical practice. It put Scotland where it should be, at the very top of what's happening in clinical medicine in the world. And it was a big collaboration across Scotland. You see another name, Colin Berry, that's Glasgow. We all can work together. Now, we therefore can say that we happily are living in an innovative, vibrant research environment. And again, some numbers for you. My colleagues wanted some numbers for our new, renewed strategy. And here they are. I'm not going to read them all, but more than 340,000 people in Scotland benefited from clinical trials, clinical research. That's great. I would like more in the future, near future. There are thousands of studies. There are more than 3,000 principal investigators, many in this room. We talked about fellows. Very importantly, top 20 big pharma companies are here in Scotland doing work. And we thank all the colleagues who are involved in this, because clinical trials benefit patients, benefit our NHS, and also benefit the economy, and we'll talk about it in a minute. This is the current, or over the last 9+ years, proportion between commercial clinical trials in blue and non-commercial. We call them frequently investigator-initiated. They're funded by UKRI, MRC, NIHR, etc., and CSO too. That proportion, I believe, is going to change. And I disagree with some of my academic colleagues that phase 3 clinical trials is not something we should be doing. We should. And if you read, and please do, Lord O'Shaughnessy review published in May and available on the website, you will see a lot of great recommendations for UK as a whole, but they absolutely apply to Scotland. We need to take it seriously because the world wants and the patients want to benefit from new medicines and clinical trials. To do all this, we need going forward, moving forward, modernizing research platform. And that's what has been provided by many of my predecessors you have seen, but we now need to move with times. We do have both national and regional infrastructure there, platforms to do all this research. Every single element on this slide is enormously important. We need clinical research facilities. We need coordinated ethics and permissions. We need biorepositories. And most of all, we need data. Data, safe and exchangeable and connectable health data across Scotland. And we will discuss it, I am sure, during all the sessions today, because nothing can happen without good health data. There is share there. There will be presentation about share later on. Hugely important. More than 300,000 volunteers who said, we will help you to participate in clinical research. And by the way, you can have our samples, our bloods, everything that happens. And that's great. Now, all this fantastic research needs then to be translated. It is not enough to leave it in our absolutely wonderful academia and ivory towers. We need to bring it to our NHS. And that requires, I believe, two things: translation and links with industry. Caroline already mentioned that triple helix partnership. Scotland is really good at it. We have fantastic academic centres. We have NHS that is truly connected across Scotland. 14 health boards, not 250 trusts. Let's use it to our best potential. But then we have industry, and I haven't yet seen innovation that matters without industrial input. I think it's really important. So you see on the left our three Chief Scientist Office regional innovation hubs, previously known as test beds. Apparently test bed is too old-fashioned, so we renamed. We need to move with times. And on the right, you see Industry Partnership Group. And I see many colleagues here who have helped us to reinvigorate this group, to bring as many industry partners, because without talking first, you cannot collaborate and innovate, I believe. There are some examples of great things that are already happening, and one is entrepreneurship. Many colleagues, many innovation fellows and other colleagues within health service would like to be entrepreneurs, but you're not born entrepreneur. There is a way to do it. And we've been hugely grateful to Mark Logan and his colleagues from Codebase, the tech scalers, to twin with us. We have two-way exchange. Colleagues who are AI, machine learning, digital experts could come to our innovation hubs, but even more importantly for me, innovative colleagues from our NHS and academia could join that school of entrepreneurship that Mark Logan bought for Scotland, and we can do it for free, and I really like to do good things for free. So another example of fantastic activities within our innovation hubs is shown here. We hear a lot about AI. Let's not hide under the table. We're already doing it in Scotland and doing really well. Our northern hub, colleagues from Grampian in radiology are currently doing a pilot, large pilot. It is working. I went to visit, grateful for the slide. It is working. It is helping patients. It is something that we can then spread across the country once we're ready, once we evaluated it. And that's the way we're going to do it. Many of you would have heard about Accelerated National Innovation Adoption Pathway, or ANIA. We'll talk more about it in the afternoon, but I know that some influential colleagues will not be with us in the afternoon, so bear with me. A little repetition on important things is valuable. So ANIA could take these innovations that come from our innovation hubs or from other places, from working as 4 nations across UK and seeing what they're doing, from international exchanges, for example, with Scandinavian countries. We can then adopt this at scale, but working very, very closely with our NHS colleagues, particularly chief executives of our 14 health boards. I said the other day, not completely truthfully, that I have spoken more to chief executives across our 14 territorial health boards over the last 12 months than to my husband. Maybe not quite true, but close. The gateway system, being really careful to evaluate first and go for that national at-scale implementation when it's ready. But we will get things wrong. You know that if you innovate and don't get things wrong, your risk appetite is far too low. And we'll expand on this with Tom Steele and colleagues in the afternoon. So Innovation Design Authority is that body, that governance body over ANIA and other innovations to make absolutely sure that we select in these difficult times, that we prioritize those most transformative innovations for that national adoption. We've started about 1.5 years ago. It's still young, we're learning, but things are happening. So when I go to talk with my opposite numbers in England or Wales, they're still discussing how to do it. We are already doing it. Help us. This is really important. I would like to leave you with 2 quotes from important new reports. The first one comes from General Medical Council. Could I have hands up of those in the audience who are registered practitioners with General Medical Council? Hands up. Great. You know what good medical practice tells us. This is the law for all of us registered with GMC. And this is first time. Of course, good medical practice has been with us for many years, since I was junior house officer in the Western Infirmary in Glasgow, and several editions. This is the first one that addresses research. There must be a reason for it. Of course, research is vital. We all know this. But I think the most important is the middle part. You registered clinical medical practitioner, will consider, should, that's the law, consider opportunities to conduct or participate in research. And moreover, you need to tell your patients when there is an opportunity to do so. This comes to practice, this becomes the law at the end of January 24. I think it's really important for us today, and I think this will come through some of the sessions. And the second is about economy, and I think that's really, really important. These are UK-wide data. This is a report by PwC, commissioned by ABPI, Association of British Pharmaceutical Industry. And it said that if successful in becoming life science a superpower, we will have all these benefits. And please note that these are not just monetary benefits. There is also 40% decrease in total attributable burden of disease, something we really, really need. So thank you very much for listening to my mental arithmetic. And we will now hear from John Saville from Melbourne.
This is John Saville speaking to you from Melbourne, where I've been based for the last 4 years. I was lucky enough to work at CSO from the beginning of 2008 until late in 2010 in a team led by Alison Small and Mike Stevens as the successor to Roland Young and the predecessor to Andrew Morris. And it's only when you come to a country like Australia that doesn't have anything remotely like NHS R&D that you fully appreciate what a massive asset CSO is to the people and health service of Scotland. I feel very honoured to be asked to speak at the 50th anniversary of CSO. I was there at the 40th. What a brilliant innovation, what a fantastic first 50 years. And although I won't be around to celebrate the 100th, I'm sure that in 50 years' time, our successors will be saying, what a brilliant innovation, and didn't they do well in 2023 to keep this thing going for another 50 years. So Anna, have a great time. CSO, do what you do brilliantly, and I hope everyone has a fantastic day today.